Is that right with Leonard Mandes? It's on my schedule. So cardiomyopathies with Ruxandra Jurkut, Professor Jurkut on Monday, and arrhythmias. But we will talk very shortly about arrhythmias today too. And we will see. Okay, let's begin. Let's do this. We will do this. Arrhythmias. Just a second. Okay, so let's talk about these ones here. Narrow curious complex tachycardias. So we have 6. We are talking about sinus tachycardia, atrial fibrillation, atrial flutter. You will do all this in your course maybe on Monday. Focal atria tachycardia, atrioventricular nodal reentry tachycardia, and atrioventricular reentry tachycardia. This is not a course. We will just spend maybe 10-15 minutes. Sinus tachycardia, is it clear for everyone how it should look with a normal P, with progressive heat up and cool down? This is the heat up, cool down phenomenon. Is it clear for you all? Sinus tachycardia, what does it mean, sinus tachycardia? When you have the heart rate over, do you hear me?
Yes, over 100, right? Hello?
Okay, over 100, right.
Minus
okay.
the age.
100 minus the age, depending on the age of the patient. Okay. Atrial fibrillation, we will not go into all this. We've seen atrial fibrillation, no P waves, irregular irregular rhythm. Atrial flutter, F waves, you know atrial flutter could be regular or irregular. Why could it be irregular? Why? When can it be irregular, the atrial flutter?
AV block associated?
When you have, yes, when you have a variable block. You've seen yesterday an ECG with 4:1, 5:1 AV flutter, and this is the case when the rhythm can be irregular. Focal atria tachycardia, it's a different P morphology. Usually it is negative in D2, D3, and AVF in the inferior leads. Every P is before the curious complex. It has different axes, the P wave. It has the on-off phenomenon, usually up to 160 per minute, and it typically, and this is a typical sign, terminates with a QRS complex. And we are talking about Michna's worries about AVNRT and AVRT, which include an accessory pathway. So for all of us, 20, maybe 30% of all of us are born with a dual AV nodal pathway. Let's try to make this as simple as possible. One pathway is always with a slower conduction. In the typical AVNRT, we have a reentry circuit in the AV node, which goes, this one here, in the AV node, which goes down the slow pathway from the atria to the ventricles, and then up to the fast pathway, and thus the retrograde atrial activation. As a result, you get a narrow here, a narrow QRS tachycardia. And why is that? Because the ventricles are normally activated through the his Purkinje system, yes? It is like this. You will have a short RP, less than 90 seconds, and if you will find this less than 50 milliseconds if you do the electrophysiologic study, but it is good whatever you find, 90, 70, just take into consideration 2 squares for this one when you talk about RP segment. And typically, you will see an S wave, typically you will see in V1 and V2. I will show you on the ECG because it's hard to explain to you. Okay, these patients have a typical clinical presentation. Why is that? Why do they look like a frog, and why do they urinate immediately after the tachycardia? So the and ventricle, because this one is retrograde activation of the atrium, are activated simultaneously. That's why you have the P after the QRS complex. And you can have the P within the QRS complex and you don't see the P wave because the atria and the ventricle are activated almost simultaneously. For that reason, the atria has to push, both the atrias, of course, have to push when the mitral valve and the tricuspid valve are closed and all the blood goes retrograde. So the patient will tell you, I had palpitations, I had rapid rate palpitations, I looked like a frog, and then I had to go urinating. Why is that? Because when the atria is full of blood, the natriuretic peptide, a consequence of the stretching, will be released diuresis. Okay, so RT, typical avian RT, narrow QRS complexes, very fast.
We can't hear you anymore.
Okay, do you hear me? I'm not sure if you hear me.
Yeah, we can hear you now.
Okay, I'm sorry. I don't know. I'm losing the connection. Just try to write me a message when you don't hear me, please. I don't know what's happening. Okay, I will share this again. Do you see the slides?
Not yet.
Not yet. That's very bad. That's for the Friday day. I don't know.
Yeah. End of the week.
End of the week, yes. I don't know. My kids are having school at the first floor, so maybe that's the problem with sharing. What is this? Okay. You're seeing this now. Okay, did you hear all the discussion from this slide? So it is clear what's a typical AV and RT for you?
Mostly, yeah, but it was kind of choppy a little bit. It was coming in and out.
Okay, let's do this again. So re-entry circuit, AV node down to the slow pathway, up to the fast pathway is slow, fast. A narrow, complex tachycardia, a narrow QRS complex because the ventricles are activated through the normal His-Purkinje system. And the atria is fast, very fast activated after. So the activation of both atria and the ventricle is almost simultaneously. This is why you get a P wave immediately after the QRS complex or maybe buried in this QRS complex. Short RP, 90, 70, it doesn't matter, just take into consideration two squares. Very fast tachycardia with typical clinical presentation with the frog sign and rapid palpitations and diuresis immediately after tachycardia. Did you hear me?
Yes.
Okay, great. So let's do this one here. Do you see P waves? Heart rate P waves. Let's begin.
Yes, P wave over there.
Sorry,
P wave exists.
where is it?
Well, actually, I see it in all the leads. Not all the leads. Lead 1, lead 2.
Where do you see it?
Lead 2, mostly.
In V1?
No. Lead 2.
In lead 2. In lead 2. I can't say that is the P wave. Are you sure this is not the P wave? Okay, this one here is the P. This one here might be a P. This one here, this one here. In V2, you only see this one, this one, this one. And you cannot say anything about D2, D3, and AVF. You see these points here is a pseudo S. In fact, this might be the S wave, this might be the P wave buried in the QRS complex. It is a tachycardia with 150 beats per minute, maybe. Rapid rate with narrow QRS complex. And that's it. You cannot say anything about this ECG. So this is the example for the AV and RT. This could be a AV and RT. Okay, we have the atypical AV and RT, and the atypical AV and RT uses just another pathway for the retrograde conduction, but not the fast one. So it can be slow, slow with two pathways, slow pathways, or it could either be fast, slow, but it does not use this fast pathway to activate the atria. And for this reason, as a result, you will have a narrow QRS complex because the His-Purkinje system is activated the ventricle, but you will have a longer RP because the activation of the atria is slower. Just it. So this one is the atypical AV and RT with a longer RP segment. What is this? It's not the atypical AV and RT. What is this? What can you see? You cannot say anything about the rate, but it is not a tachycardia here. Just tell me what you see. Do you see P waves?
Yes, you can see P waves in this one.
Okay. PR segment. P, 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 V1, a P here, biphasic, P, P, P. Okay. PR segment. It looks short. I know you don't have squares, but it rather looks short. So you have to look at the QRS complex. Let's enlarge this. How does the QRS complex look like? It is not large, but it is slurred. The upslope is slurred. This is a delta wave with a short PR segment. And this is a patient with Wolff-Parkinson-White syndrome. WPW, I will refer to this with this nomenclature. So, in WPW, we have the sinus node. The sinus node is firing. It gets to the AV node. And then two things happen at the same time here. The first, we have the conduction through the accessory pathway. This is the accessory pathway. This is the node, the normal AV node. The accessory pathway is conducting. This is working myocardium. It is not specialized AV nodal cells. So that is why you do not have any delay. You don't have the AV conduction. You have the direct conduction here. This is wrong. You have the direct conduction here, and you have a shortened PR. But you are not connecting to the specific His-Purkinje system. So as a result of that, the speed of the conduction here is slower, and it will get you the upslope, which is flirt, the delta wave. At the same time, the conduction through the AV node, it's happening. So it normally hits the His-Purkinje system, and the QRS complex is then normal. This is the pathophysiology for the WPW. Okay, and one thing that can happen in this syndrome is the orthodromic tachycardia. And the name comes from the way the impulse is conducted through the normal AV node, through here, and back retrograde to through the accessory pathway. As a result, the ventricles here are normally depolarized, so are normally activated. And the QRS complex would be how? Narrow, because the activation is normal. So the QRS complex in this orthodromic AVRT would be narrow. It's a very fast tachycardia, regular tachycardia with a long RP, the same as a typical AV and RT. But you have to know that the atria and the ventricle are not activated simultaneously here, because this one here, you know, this is working myocardium. It is not AV nodal cells. And that's why the atria would be activated slower after the ventricle. So the PR will be longer. The RP will be longer, more than 90 milliseconds. Why don't you see a delta wave in this orthodromic AVRT? Can you tell me? Yes, no, just to know you are hearing me. Why don't you see a delta wave in during the tachycardia? Do you hear me?
Yes,
Yes, we hear you.
I will tell you why. Because
maybe
you... Okay, tell me if you want.
for the VPV, it would go kind of the other way, and the ventricle takes longer time to depolarize, and this shows on the delta wave because it's slower. But
Okay, because the ventricles first depolarize normally. So you do not see a delta wave because the activation is normal. The QRS is normal and it is narrow. The sense is like this, AV node and back via the accessory pathway. That is why. Okay. The brother of orthodromic is the antidromic, and the sense is the other way around. So you are conducting through the accessory pathway and then retrograde through the AV node. So you will have a wide QRS complex, a wide because this one here, this zone is working myocardium and it is slower, and a long RP. So you will ask me how to differentiate these two. Maybe this is why Mikna asked me to revise this. How do you do the differential between a typical AVNRT and orthodromic AVRT? Because both are narrow and both are and the pathophysiology is different. So you kind of don't differentiate these ones. You have in AVNRT a pseudo R prime in V1, as we have seen. This is in fact that R prime is in fact the P wave. You would have pseudo S in D2, D3, and AVF. These ones here are the P waves. And you can make this calculation, RP in V1 minus RP in D3, and if it's more than 20 milliseconds, it will probably go for AVNRT more than AVRT. But you don't usually, you cannot tell on an ECG the difference between these two. And you should go for the electrophysiologic study in this case. And the ablation is a very good treatment for both these arrhythmias, for both these tachycardias. Okay, in the end, just to end this story with supraventricular tachycardias, because we are not talking about narrow tachycardias, but this one here is a chart for differentiating the narrow complex tachycardia. And to be simple, if it's irregular, it's atrial fibrillation, and it's all you should know. It could be multifocal tachycardia, atrial tachycardia, but it's good for you to know it's always atrial fibrillation. If it's regular, you have to look at the P waves. If there are no P waves, because they are buried in the complex, in the QRS complex, is for sure AVNRT. But then if you have P waves, you have to look and to calculate if the rate of the P is rapider than the ventricles, it could be atrial flutter or focal atrial tachycardia. But you see here, when you have the RP less than PR and the RP more than 90 milliseconds, it could be any of the following: AVRT, a typical avian RT, or focal atrial tachycardia. So you will need to go for an electrophysiologic study, and it's not very simple to differentiate these ones on the ECG. Okay, you will talk with my colleague on Monday. If you have any questions, or if you have any questions now, we can talk. Mihna, what was your question about this?
It was related more to the AVNRT, that
Okay.
between the typical and the atypical, because I've seen some people say that in the inferior leads we have negative P waves, and in V1 we have
I lost
positive
you.
ones.
Okay.
So like in
Continue.
lead 2-3 and AVF.
Okay. Can you repeat, please? I'm sorry.
Should I repeat? Can you
I lost.
hear me?
Okay, can you write?
Yeah, sure.
Because
Sure.
it's not good. Okay, do you see the slides?
Yes, we do.
Do you see the slides?
Yes, we can see the slides.
Okay, it's awful. Today is not a great day. Try to have some fun with the case. If the internet connection will let us, when it can get complicated. So, we have an 80-year-old female patient presented for severe dyspnea with orthopnea and altered general state. Nice. Anamnesis. I'll have to ask you to talk permanently with me just to know I'm here, because I don't know I'm here.
You're here. You're here.
Okay. Tell me what film you've seen yesterday. Tell me anything. How's the weather outside? Because I'm in here for a couple of days. Tell me anything. I don't mind.
We should ask her how long she's had these symptoms before she was admitted.
She has the symptoms. I will have to look. She has the symptoms for a couple of years, and she was hospitalized for several times. But now the symptoms aggravated in the last 2 weeks.
Does she have any known major illnesses or diseases or anything?
I don't hear you.
Does she have any known illnesses? Or
Nicholas, can you repeat, please?
Can you hear me?
No, we cannot do this. Let me try to end one of the meetings because it's not possible to work like this. I will end this one here. Okay, so I don't see any of you now. Let's try to talk again and see if it's better. Do you hear me? Am I still here?
Yes.
Okay.
We can hear you.
Okay. Great. Nicolas, tell me again, please.
I said, does she have any past known illnesses that we know about that she said?
Cardiovascular illnesses or not?
Yes, cardiovascular illnesses.
Okay, so she knows she have a problem with one of the valves, and she was admitted 6 months ago for aortic endocarditis. She was treated then with the antibiotics, and she has diabetes, treated with medication.
Okay.
I don't see any of you, but I hear you. It's okay like this. We are in the dark. Go on.
Family history?
Family history. She's 80 years old, yes. So she can tell. But her parents died at the same age, something like 80, 79, with no cardiovascular diseases known.
Can we ask if she's undergone any type of surgery or if she's taken any other medication other than the antibiotics and the diabetes medication?
Oh, great. Yes, she's taking furosemide, she's taking spironolactone, she's taking some ACE inhibitor, but I don't know what kind of ACE inhibitor. She's taking a statin, atorvastatin 20 milligrams, and that's it. And the beta blocker.
I think a common question for the orthopnea could be also how she sleeps at night, like the pillow thing, how many she uses.
She uses 3 pillows to sleep at night. She's waking up because of difficulties in breathing, and she needs to stand in order to sleep. Okay, what is important? Allergies. You didn't ask me about allergies. And be sure to always ask about cardiovascular risk factors because you don't. So, does she know she has a high level of cholesterol? I don't know. She's taking a statin, so she has dyslipidemia. And ask me or anyone about the maximal blood pressure experienced until now, because you can classificate the stage of the hypertension. Yes, it is important. So if she smokes, if she has hypertension, if she's dyslipidemic, if she has diabetes, it is important. Okay, let's go further. So risk factors: age, hypertension, type 2 diabetes, dyslipidemia, endocarditis in May 2019, treated with antibiotics, and diagnosed with heart failure some some time. Clinical examination. Clinical examination.
The blood pressure.
Blood pressure 140 with 95 millimeters mercury. You're near the patient. Just imagine what you do and tell me what you do. I'm asking you because you are not near the patient, and when you get to the hospital, you spend 5 minutes asking questions, and it is not enough. And then you spend another 1-2 minutes near the patient to seek some clinical signs, and then you just exit the room, and it is not enough. So I want you to imagine you're near the patient and you want to find out things about that patient. What do? You take the blood pressure, you verify things, you put your hands on the thorax, just tell me what you do.
Auscultation. Maybe heart sounds. Does she have any murmur or anything?
Oh no. I'm out? Again?
We can hear you now. You were quiet for
Okay.
a few minutes there.
I was quiet again, so you didn't hear anything.
No.
No.
We heard your explanation, like about what we would do in front of a patient, and then we answered.
Okay.
But then it was all quiet.
Okay, because I didn't hear you. Okay, I'm sorry for that. I don't know what's happening. It seems nothing happens, but I don't know why.
We asked the temperature. We can see the respiratory rate and the pulse rate.
Great. The temperature was normal. The respiratory rate was 26 per minute. The heart rate 90 per minute, and the saturation 85% in the air. She was orthopneic.
Yeah, auscultation. Any murmurs?
Yes. Murmurs, systolic murmur, grade 3 out of 6 in the aortic area, radiating on the carotid arteries. And there were some subcrepitant basal bilateral on the both lungs, in the both lungs. Okay, so cold extremities, this is an important issue. And then you have all the parameters you've asked for. Let's try to have the first diagnosis to put this patient into a syndrome. What syndrome could it be?
It could be heart failure.
It could be heart failure, yes. And why is that? Do you have any other clinical sign that a disease might be to lead to heart failure?
Maybe the systolic murmur.
The systolic murmur, yes, the systolic murmur into the aortic area irradiating through to the carotid arteries. What could it be?
Aortic stenosis.
Oh, great. Aortic stenosis. Let's see. Let's see first the ECG. We will have a very short session today. I can't wait to finish this case because we are not hearing ourselves very good and the connection is very poor and I don't know why. Let's see the ECG.
It looks like sinus rhythm. We see the P waves and the heart rate is 75, so it's normal.
Okay. Okay, what else?
Left axis deviation.
That's it?
Left axis deviation.
Left axis deviation, I agree. What else?
Left ventricular hypertrophy.
Do you have the criteria for left ventricle hypertrophy?
I think in AVL the R wave is pretty high, and
Right. So you used Kernel in AVL. Yes, you're right, because you don't have the criteria, the Sokolov-Lyon criteria, and you have the Kernel. Great. So more than 11, yes, in AVL.
yes.
And that's it. You have some negative T waves in the lateral leads, and this could be due to ventricular hypertrophy. Okay, so the biology, lactate 4, antipro BNP over 30,000, glomerular filtration rate of 15, hemoglobin 10.8, and some inflammation with an infection with E. coli in the urine. What is this? So let's remember for the acute heart failure, the 2 minutes assessment, bedside assessment. Can you integrate this patient into a profile? Because she had congestion, pulmonary congestion. It was a kind of cardiogenic shock. Don't you agree? With lactate more than 2, hypoperfusion, cold extremities, very high NT-proBNP, the diuresis was not present. It was mixed cardiogenic and septic shock, something like this, because she had these markers of inflammation. Okay, I don't know if you're seeing very, very good these films here, but just look at this one. Here you will see a long axis view with some modifications. Do you see anything on this film? Is there anything that bothers you? This one here is the short axis, but it is not very good. The quality is not very good. And this one here is the aortic valve with many artifacts, is not looking good, but it is not opening for sure. And this one here is a 5-chamber view with a turbulent systolic, how do you call it? Flow. So here, do you see anything? This interventricular septum, is it okay or not? Okay, thickened ventricular walls with a valve that is not opening and it is not closing very well, and a very turbulent flow here. This is not a very good image. And this is the velocity of the flow through the aortic valve and the criteria for establishing the severity of the valvulopathy. And the maximum velocity through the valve was 4.5, and the gradient, the medium gradient, if you just trace this envelope here, you will obtain a medium gradient of 52 with an area of 0.5 centimeters, and index it might be less. What do you think? It is a moderate, it is a severe aortic stenosis. You have the criteria for severe aortic stenosis, and you should know all this for your exam, because it could be a potential subject into your exam, the severity of aortic stenosis.
It is severe.
It is severe. We will get through the criteria in a couple of slides. And this one here is the envelope, the gradient between the right ventricle and the right atrium. It's 92. So probably we will have a systolic pulmonary pressure very, very high. This patient has some problems. Okay. The therapeutical plan, what do we do? So we admitted the patient in the ICU for the non-invasive pulmonary ventilatory support with CPAP, diuretic, antibiotherapy with a favorable evolution without needing the inotropes. What do we do next? What should we do next? She is good, she is treated, she is almost decongested, but the future is not good for her. What do we do? How do we manage this patient? Okay, first let's talk about investigations. We have the ECG, we have the echo, we have the biological assessment. What would you need more? Is there anything we skipped?
Exercise testing, can we do it, or it's not indicated?
Exercise testing when the patient is so fragile, in 80 years old, and presented with acute heart failure, no. It's not the proper moment, and you do not have an indication, because you saw in echo that the aortic stenosis is severe, so it's contraindicated to do this. What could happen in an exercise test in aortic stenosis, severe aortic stenosis? What could happen? The main symptoms of aortic stenosis, let's go through this. Another subject in your examination, and it could be a subject. Please describe the symptoms in aortic stenosis, or symptoms and signs in aortic stenosis.
Chest pain.
This might be a subject. chest pain. And why is that? What are the reasons for the chest pain? It could be an associated coronary artery disease, right?
Also,
And could lead to,
yeah.
go ahead. Also, what else?
Tightness in the chest,
Sorry, repeat.
like a tightness in the chest.
Yes, of course, angina. These patients could have angina, but why? If they don't have coronary artery disease, what's the reason for the angina? What happens when you have an obstacle and you have this stenosis, severe aortic stenosis?
It blocks the blood from your heart to the aorta.
Great. And how does the ventricle react at this?
It pumps
What changes
harder.
Compensatory hypertrophy? Yes.
Yeah.
So in order to maintain the stroke volume and the cardiac index, the ventricle is getting hypertrophied. And what next?
It demands
There is an
oxygen.
imbalance. Yes, of course, the imbalance for the supply and demand, and then angina through the microvascular disease, because you don't have all that thickened ventricle vascularized. This could be another reason. There are more reasons for angina, and this causes too. It could be some, I don't know, compression, coronary compression. In cases of severe left ventricular hypertrophy, it could. So there are many causes for angina in patients with aortic stenosis. Another symptom.
Dizziness and fatigue.
Dizziness, fatigue, of course. Syncope?
Yes, also.
Yes, of course. Syncope could be, and dyspnea could be because of high pressures, and syncope because of low debit cardiac index. Okay. Arrhythmias maybe? Palpitations due to arrhythmias? And why? Okay, read this stuff. So read the clinical examination in aortic stenosis, because you can get it into your examination. But we were talking about ECG, echo, biology. You need more. So not the ECG testing, the exercise testing. What else do you need in this patient? When you are talking about investigations, what are the investigations in aortic stenosis? Radiography, do you need it?
Yeah, an X-ray would be helpful, I think.
X-ray, okay.
Cardiac MR. We can assess
MRI.
the MRI, yeah, for the fibrosis.
Yes, it would be very, very nice, but not in our hospital. But yes, it would be lovely to have this here. Great. Maybe a transesophageal echo. Would it be helpful?
Yes.
For what? just imagine, why are we doing the transesophageal echo? Okay, we will talk about this one. Let's go further and we will hit this point in a couple of slides. Okay, so the essential questions in the evaluation of every patient, because you know the treatment in severe aortic stenosis, the final one and the best one is valvular intervention to change that valve. But which intervention are we talking about? Because we have interventional approach and we have surgery. So the first step is to determine how severe is the valvular disease. And we are talking here not only for aortic stenosis, but for every valvular disease. How severe is this? What is the etiology? Rheumatic, degenerative, it could be something, or maybe endocarditis, we will see. Does the patient have symptoms? We have to establish this one. And are the symptoms related to the valvular disease? Are any signs present in asymptomatic patients that indicate a worse outcome if the intervention is delayed? This is not the case in our case discussed here. What are the patient's life expectancy and expected quality of life? And this is a very important parameter to know whether we will choose intervention or we will choose surgery. Do the expected benefits of intervention outweigh its risk? What is the optimal treatment modality? We will have to establish this. Surgical valve replacement, would it be mechanical or biological? Would it be surgical repair or catheter intervention? Are local resources optimal for the planned intervention? And we have the possibility of doing both, so surgery and interventional. And what are the patient's wishes is the last point, but it should be the first because it is very important and he gets to choose the life he wants to live, or he can refuse the therapy. So the first to come is assess the severity of the disease. And you have here the criteria for severe aortic stenosis, the echo criteria. And you should know this: the maximum velocity through the valve over 4 meters per second, the mean gradient over 50, and this is the cutoff, I think, for the Americans, because we have the cutoff of 40, over 40. The aortic valve area under 1, and if you index this value should be under 0.6 centimeters per meter square. And this established the diagnosis of severe aortic stenosis, and you should only know this part and not all this here. Okay, second, etiology. Just go through the etiology by yourself, and we will hit this one here. Treatment option: management of severe aortic stenosis. The patient have symptoms, and we all agree she does. We are in this part here. If the patient does not have symptoms and the LV ejection fraction is not below 50, so in this case we should reevaluate the patient every 6 months and see when symptoms occur. If the left ventricle ejection fraction is under 50, then without symptoms, we should do the surgery. But in this case here, when we have the symptoms, we have to do more. First of all, we have to establish the absence of comorbidity or the general condition that make benefit unlikely. Do we have such conditions? Do you hear me?
Yes, we can hear you.
Okay, so we are not allowed to go for surgery or for intervention if there are comorbidities and the intervention doesn't have the potential to improve quality of life or prognosis. In this case, the patient should be treated medically, but this one here for our patient would not do many things because the patient is hospitalized every 2-3 months and she's getting worse and worse and worse. So we have to do something because the medical therapy won't help her, and she does not have severe comorbidities. She does not have cancer. She can be mobilized, so she has a good prognosis, a good 1 year prognosis. So expectancy of life should be more than 1 year when we choose TAVR or surgery. And we go further to establish the low risk or no other characteristic that favors TAVI. What does TAVI mean, or TAVR?
Transcatheter
Yes,
aortic
yes,
valve
great. This is the one,
implant.
the interventional approach, and we will see. Okay, what do we need for surgery or any other intervention? We will need an S is missing, transesophageal echo, and this one is good for establishing the severity, but we have seen it's a severe disease. For describing the valve from measurement of the aortic annulus, the ascending aorta, and to establish the approach, because we can have, when we are talking about the interventional approach, we can have the transfemoral approach or the transapical approach in cases of severe atherosclerotic peripheral disease. We should always do a coronarography. And why is that? Before every surgery, because we can get this patient revascularized before the intervention. Even when we are thinking about angioplasty, but if the patient have trivessel disease, we cannot go for TAVI without resolving this issue, because the patient could suffer myocardial infarction during the intervention. So coronary angiography recommended in every patient with history of cardiovascular disease, with suspected myocardial ischemia, and the patient had angina, with LV systolic dysfunction. The patient had an ejection fraction of 40%. I forgot to tell you. In men over 40 or women in postmenopausal state, and one or more cardiovascular risk factors. And CABG is recommended in patients with the primary indication for aortic or mitral valve surgery if they have stenosis over 50%, and this is a class 1 indication. Besides coronary angiography and transesophageal echo, we have the possibility of doing the aortic CT scan, which can provide us with some wonderful information and 3D reconstruction of the aorta, of the aorta's diameters, in order to choose the proper biological prosthesis when we talk about TAVI. And these are the things we have to do before the intervention. We start with the coronarography, and I can tell you in the right you have the right coronary artery, and in your left you have the LAD and the circumflex here, but there are no issues, and the coronary arteries are normal in this patient. So we are getting here to characteristics. No, here. Let's go and see what's the characteristic for the TAVR. So this is the interventional approach, and CAVR, this is the surgical approach. If you have plenty, and I will not go through these ones, anatomical and technical aspects in favor of one or another one. If you have a short distance between coronary ostia and the aortic valve annulus, if the size of the aortic valve is out of the range for TAVI, if the aortic root morphology is unfavorable, and so on, you will have to choose surgery in a patient aged 80. So it is quite problematic. You have the clinical characteristic too that favors one or another one, and in all these patients you should calculate some scores to provide the risk rates, and if exceeds 10%, then you should go for a interventional approach. And there are some cardiac conditions that require consideration for concomitant intervention, and these are severe coronary artery disease requiring revascularization. It is not the case. Severe primary mitral valve, it is not the case. Severe tricuspid valve, aneurysm of the aortic ascending aorta, or septal hypertrophy requiring myectomy. All of these favors the surgical approach. So we have the indication TAVR or surgery, and the patient have a neuroscore over 10%. She had 8 years old. She was very frailty, so we decided for, these are the reasons we have decided for the TAVI intervention. TAVR or TAVI is the same thing. Okay, the heart team decided for this one because we have heart teams. The heart team include the cardiologist, the interventionist, the surgeon, the anesthesiologist. All these people are the heart team, and they decide the cases. So intraoperative TE, transesophageal echo. You cannot see very much in here. Let me just no, it is not important for you, this one here, because you won't understand anything. What do we do? So we just enter and predilate with a balloon, but maybe it's good to see this one. Let's see this film together, and we will talk about this. You can find it on YouTube. Do you know what this intervention means? So you get inside, transfemoral approach, descending thoracic aorta, and then you go with the wire catheter through the aorta. You just dilate, pre-dilate, then you go back and take all the mechanism of the valve to implant the biological valve, because this is a biological valve. This is the system that goes until it reaches the aortic valve. You see here the valve is not working properly and it is severe calcified. Okay. You try to fix the valve in a proper position, not to obstruct the ostium, the coronary ostiums. And then rapid pacing for the heart to stay still, rapid pacing with 180, and then the deployment of the biological valve without removing the older one, without doing anything else. And then you should dilate with the balloon, but this is the intervention. And it's not without risks, because these patients are generally very old and have comorbidities, and this patient, she had chronic kidney disease and diabetes. She was hypertensive, so you can say she was a fragile patient. After the intervention, so you had a maximum velocity of 4.6. After the intervention, the velocity dropped to 2.3, and the medium gradient 7 compared to 52. This is a good result, a very good one after the intervention. So the evolution now, with rapid hemodynamic collapse, arterial hypotension, what could be the cause of this? Shock, what kind of shock? Tamponade, acute coronary syndrome, aortic dissection. These are complications that could happen after the TAVI procedure. The patient's evolution was not good, severe hypotension, and we just looked into the pericardium and we saw pericardial liquid in moderate quantity with the hemorrhagic aspect that collapsed the right cavities. And we decided this is clinically and echocardiographically cardiac tamponade, and intervention was needed, an emergent intervention was needed with pericardial drainage, and then some tubes were left inside to maintain the drainage for longer hours. But the patient had an undulatory evolution with multiple organ dysfunction syndrome, and this was her ECG in the ICU. What do you think about this ECG? The troponin was almost 4,000. Just describe what you see if you do see something. Just describe. Do you hear me?
Yes.
Yep.
Oh, sorry. Okay, should I return to her baseline ECG? Let's go back and see what the ECG was like. So we are here. Just look once more here. And now we have this one here.
Her heart rate decreased a little bit. I don't
Okay.
know.
Okay, what else?
The hypertrophy is greater.
It's about the device, the ECG device. I don't know if that's the case. The hypertrophy could not be increased in 2 weeks. Let's look in D2, D3, and AVF maybe.
Yeah, I think the ST segments were different. Also, in
Yes.
AVL, I think was.
Let's see here. So D2, D3, and AVF here. Just look. And look in V4, 5, 6. And let's see if something is different here. It is. It is an ST elevation, and it is clear in this area here. D2, D3, AVF slightly goes up here, but you cannot tell. This is the isoelectric, the baseline, so you cannot tell, but something is happening because she has these T waves, and this is not a good sign. Cardiogenic shock with the high troponin after the second intervention. Okay. An emergent coronarography was repeated. This is the valve. So it is like a stent. It stays in a huge stent, the biological valve here. And what do you see? Here is the right coronary artery. And what do you see?
Stenosis?
Yes, occlusion. Oof, it's stopping here. So the right coronary artery, occlusion in the second segment, the first one and the second one. And here you see a drainage tube that makes compression here, and eventually as a consequence, the patient get it on myocardial infarction with severe thrombosis, coronary thrombosis on the right coronary artery. A stent was placed, but no favorable evolution occurred. So refractory cardiogenic shock after this, and the patient died. But this is not the reason I presented you this case. I wanted to talk to you about how you approach a patient with a valvular disease, and what are you looking for in order to decide if you go for the surgery or for the interventional approach, and just to make sure you are reading the aortic stenosis for your final exam, because you will have plenty of questions from this area. So multiple complications can appear after TAVI. This patient, cardiac tamponade, iatrogenic myocardial infarction, exitus. These patients have a lot of risk when doing something like this. Okay, so that's it. I'm sorry if it was, oh, I have no camera here? No camera.